ये मैं
दूसरी वाली में लगा लूंगा।
अच्छा शेयर में कर रहा था, ठीक है। ओके, इट शुड बी डन नाउ।
दो तीन में खुद ही रखे, मैं दोनों आ गए।
ठीक है।
और
ओके।
कंडीशन है इसका तो भी लिखा है एग्जाम। ना कोई मसला हो तो ना कुछ और को पढ़े तो भी।
कैन यू हियर मी? आप सुन सकते हैं ना मुझे लोग?
जी सर, आपकी आवाज़ आ रही है।
यस।
ठीक है, थैंक यू वेरी मच, थैंक यू वेरी मच। Okay, sorry for this disruption. I think every 40 minutes they have to reconnect it. Well, the number of participants has gone down. Okay, no problem. Okay, so here we were, and now we move forward. Mm, okay. I will go back. Okay, now if you see that we have, you know, can't take this one away. Come on. Okay, now we have performance management key performance indicators, or called KPI, and monitoring and reporting system, in which I would like to mention, you see that at the top, if you see, we have, let's see, yeah, these are the key performance indicators you put in any kind of monitoring system. For example, the number one I put here is the essential medicines availability target, that just given that as it should achieve 95%. Number two is maximum wait for the elective surgery should be between or less than 48 hours, about 2 days. Third is that less than 2% there should be hospital acquired infection target to meet. And lastly, is the doctor attendance verification, which should be 100%. So these are our KPIs. And if you see, these KPIs need to be met. So there are ways that we can do best part on our key performance indicators. For essential medical availability, we need to plan ahead how much medicines we need. Then we need to look at the elective surgery timings, that how many patients we are getting in and how many doctors and operation theaters we have and how we can manage. The third one is acquired infection control target is very important. It starts from the top management to the lowest tier of the hospital, where it is important that we keep the best practices of infection control and prevention. And lastly, the attendance verification. There are different systems that can be used, maybe registers. Now we have those machines to see who is coming in at what time, going out at what time. So these are different KPIs which can be reported. Now, secondly, if you see on this slide, is the monitoring and evaluation framework. And there are different steps. The first step is the input monitoring, because now what I'm talking about here, this framework will definitely have an impact on these KPIs. The first input monitoring is whether the budget has been released or not. Do we have staff there, enough staff in the hospital? Do we have all the procurement available? Our hospital infrastructure is ready. The building is okay, it's clean and everything. This is the input monitoring, what we have in our hospital. Then the second part is the process monitoring, and this, that we are going through a process. Are we going through all the standard operating procedures? Are we going through the patient numbers? How many are coming in? How many are going out? How many are getting treated? How many are getting better? What is the role of what is the situation in the theaters? How much it is used? How much it is utilized? Maybe only two or three surgeries being done a day, or the OPG utilization, it is heavy, or it is one day it is less, one day is more. You need to have statistics or monitoring the processes, all these processes then accumulate, and then you look at the output measurement. In output measurements, if you see that those two will lead you to the numbers of OPDs and IPDs, inpatient department and outpatient department. What are the rates of references and how many prescriptions have been written, how many operations have been done, how many surgeries have been done, how many treatments have been given. That is the output measurement. And lastly, the outcome at the national level, we look at what is the maternal mortality rate. Is it coming down? Is it infant mortality under five mortality is also coming down? What is the incidence of the disease? Patient satisfaction? Is it good, bad, poor? All these need to be evaluated, and that is part of the monitoring and evaluation framework. It can be put in many of the hospital, any of the health department or a section where this can be done. Moving next to, as I've already mentioned, that the transparency tools are important. Here, they have very pertinent areas where we can work together with the community. For example, number one, we say citizen charter. That means the hospital, it should be written out that everybody who comes in will get the free treatment in a public hospital. And if they have to pay 1 or 2 or 5 rupees, it should be placed at the outside so they do not come in and say that you never have written anything, you have not displayed anything, and you are asking for this. So you can save time, you can get the best out of the patient. Open data portal is that what you can public the data of the hospital, how many people got sick due to these diseases, what is the incoming patient, what the outgoing patient. If they have that, this is an open data portal that, for example, in Services Hospital or Jinnah Hospital or Mayo Hospital, LGH, Fatma Jinnah, and anywhere, they would have all these statistics available. And if they put it on the portal, people will understand what is coming in and what is going out. Thirdly, is the grievances. People are not happy sometimes. They have their odd grievances, so that should be looked into where who is to be blamed, whether it is on the health side or it is on the community side, and there should be a way forward to deal with that and to communicate in a proper way and have evidence. The fourth one is performance scorecard. It has to be very importantly done that what is the budget that came in, how was your performance? Because there are sometimes when you look at the scorecards that how many in patient came in, how many outpatients were there, how many surgeries were done, are there how many patients suffer from hospital-acquired infection, and so on. All these list would be there, and on that performance, you say that this is a very top performing hospital, and then you will have middle performing, and then you have low performing based on these performance scorecards. Fifth one is social accountability. We are all responsible to our social network, our community. So that's why we need to participate. Though what I've written here is the participatory budget should be reviewed with a civil society engagement. I don't think so. It is done at that level, but at least we can have a sitting with them to understand what is their what are their needs, what are their priorities that we can bring in the next budget or in the same budget to get more money, uh, provide them that kind of treatment, or we can give them that kind of service. I'm sorry. The lastly, we have the right to information under the Transparency Act of Punjab of 2013. Every citizen has a right to all kinds of budget records, procurement decisions, inspection reports, and so on. They say 14 days. Maybe it is correct. I'm really not sure from where the source I got it. It was written there, and I did speak to a few people on this. So, right to information as there. So, if you see these all transparency rules or the tools, if you use, in the end of the day, you will not be asked anything because you have done everything in a very transparent way, and you are all well. You are all good. Anti-corruption laws and practices in health system. Well, I've given the legal frameworks here that starts from prevention to National Accountability Ordinance, Punjab Employees Efficiency Act of 2012, PEPRA rules of 2014, which is mandatory competitive tendering, and Punjab Transparency Act of 1213. So I don't want to go into the details of these legal frameworks, but what I will do is what are the common corruption practices in Punjab Health Department or in health department, what people do. Uh, Bear with me. This is based on information from different reports. Talk to different people. There are some reports. The first one was the ghost employees on payroll. And I am sorry to say that I have an evidence on that. It has been happening and people were penalized. Number two, procurement kickbacks from suppliers, another common practice, unfortunately done. Unofficial charges to patient that happens in the hospital. Sometimes even the door staff, or God forbid, things happen. They get money, which is unfair, and it is happening. But if we are trying to do, if you cannot go to zero corruption policies, at least you can reduce that. And that should be the way forward. The fourth one is drug diversion to private practice. This has been also reported in the practice that the medicines come out of the government hospital and goes to the private practice. And then, last but not the least, is the attendance fraud and absenteeism. This is a very touchy point. If you ask me how to deal with it, because doesn't matter you put 10 gadgets for the fingerprinting, face printing. I worked in one of the organization where even they did not believe in fingerprinting and even they didn't feel it, they didn't put anything else. They put a camera, at least that you have to show your face you come in. Even in for fingerprinting, sometimes others can just punch in. If you have some number to punch in, people punch in. With the face they tried, but still people would not, because the problem here is that if there is no incentive, there is no, something for the employee to come in and do the best, but not only the financial part, but it is your technical part that you feel satisfied doing something in a very best way. So you will love to work, you will love to come to your workplace and do things. So what could be the institutional countermeasures? I've again put similar things that the biometric attendance to all BPS 1 to 17 staff, the junior staff. What about the senior staff? Uh, do you think that they come at time? I think it should be for all the staff. E-procurement with public publishing of all contracts. I think this has been done now. Now with this e-procurement, people do publish because all the things are tendered and then it happens. But still, there are some catch points. Independent pharmacy management and drug stock audits. You need to look into the audit system of the pharmacy, how you manage it at the bigger hospitals, with the pharmacists and with the other administrators. Uh, Zero tolerance policy with documented sanctions. We should not tolerate anything on the with whatever somebody deviates from the policy. That something is forbidden not to be done and people are still doing it. I think there should be zero tolerance to that for the especially managers at your level. Lastly, annual asset declaration for BPS 17 plus officials that, wow, I think this is what the NAB and others anti-corruption people are doing. But these are very hard points to digest. You would say that, Doctor, you're talking about this. Yes, we know these are the problems, and still these things are on. My point here is not to tell that what is wrong and what is right. It is what is there. And then nothing is perfect in this world. Leave you to me. Whether you are in the first world countries or the topmost countries, still things are happening, but at the lower level. And it means at the less level, means they're not very rampant. So the reason, just explaining all this, is that this is an ideal situation which should be done. But what again I say is that there should be a workable area where we should come and give the best practices, best knowledge, and best services to the people. Moving on, I try to do institutional governance improvement SWOT analysis. This would be, I think, second last slide, I believe, because we are reaching about 1 hour. So I should be finishing up and then we'll have some question answers. The strengths, if you see, there is a licensing now. We have Punjab Healthcare Commission, which is doing an excellent job in licensing and inspection framework. When I was working at the junior level, at that time, there was nothing like that. There was no institution coming and looking at people who is practicing where and doing what. Then we have DHIS 2 data, which is a reporting infrastructure, is at good place, is a perfect place. Community health worker network is already there. And then we have procurement system for provincial medicine that's called PPSC. So these are the few strengths I have pointed out. The weaknesses are definitely weak internal audit independence. People are influenced easily. Political interference at the staff level is there. Uh, there is limited management training for clinicians. I believe you me. I'm a public health practitioner. I had that very difficult time working with our clinician, clinicians or our colleagues in the clinical side. Uh, they see things very different. But we, as a public health people, we have to bring them together because they are part of us. They're part of the health system. I can give you an example. My own life. At one time, I think I was working for World Health Organization at that time in Pakistan, and I was doing something on healthcare waste management. And I went to one of the principal of the medical school. I will not name that. I was doing a workshop of 25, 30 people all over from Punjab. And he said, Doctor, what are you doing? You're a doctor and you're talking about this garbage and this and that. This is not your job. I said, no, doctor. He was senior to me, sir. I said, no, sir, it's not that way. It is that what we're trying to prevent is because of these syringes which are being used or reused, the syringes and the needles, that has raised a concern about hepatitis B and C and HIV/AIDS. And that was the time that clicked because once he heard the words Hep B and C and HIV/AIDS, it stuck in his mind that okay, there is something that it is to be done, or it is concerned with the clinical side. If I just say that we are here to just see the waste management, he said, oh, I have nothing to do. Go to the municipality, go to the EPA or whatever. So I think they need to be part of the management so training programs. Trainings are very important. Maybe this training that you're going through, maybe half of you are attending or half of you are not attending, or even if you just grasp one slide, that may be able to help you in your life somewhere. So never underestimate any training. No training is a bad training. Training is an excellent tool to improve yourself, to look at what are you doing? Are you doing the right thing? And are you doing your things in the right way? Again, I come back to that. And then let me finish this. I'm just drifted away with those kind of stories come into my mind. So the opportunities are the digital monitoring, e-procurement expansion, civil society in the health sector is engaging. We have a Punjab CM inspection team is reforming and they are helping people to better perform. International donor support is there. Well, some people would ask, why, doctor, you're saying that this FCDO, World Bank, I did one project with FCDO just now. Sometimes these donors, they're helpful because we don't have expertise or we don't have that kind of money to spend. And they train, they help. But it depends how we utilize that. Is it just one training? They give us a booklet and they take money and go bye bye? No. It is the we are the on the receiving end, right? If somebody has come from these organizations, they said, okay, we are going to give you $1 million and we will train this and do this. It depends on how many people are trained very well. So it is, they will just provide the training and go home. They would not be caring about anything. But on our side, it is important that we get the maximum out of that kind of opportunity may not come in years to come. That is really important. So seize it, take it, do it, and do it in the best way. Lastly, the threats. Well, criticize appointment stuff. Definitely, it is there. Budget constraints, informal payments, corruption, brain drain. Why? This is a very touchy subject. I was part of that because I left my country for. But I wanted to work with World Health Organization at the international level. That was my passion. But I think I was part of this brain drain as well. I was assistant professor here at the Institute of Public Health for from 1994 to 2000, and then I joined WHO and went out, and now I'm back after I think 23, 24 years. So this is happening. This is very important. Why our health people they work so hard, doing MBBS or BDS or even nursing or whatever. We do a lot of hard work. We do a lot of put a lot of effort, and in the end of the day, what you get, nothing. A doctor is getting, unfortunately, I was told in the private sector, they get not more than 40 to 50,000 rupees a month. This is a joke for a doctor. Though in I think public sector they're getting better, but in private sector, unfortunately, why? Why? I mean, means they are the best people. They are the cream of the nation. They're the best brains, and this is the way to treat. And then they will go out. But this is again, it comes at the policy level. We need to make better policies with mushrooming all these medical schools. Okay, it is a right to have a medical school, but the thing is this, it should be driven in a way that how much is the need? Do we need that? Still, we need doctors, but are they making the right doctors, the right place? On the preventive side, a young doctor coming out of the house job, he thinks that I'm going to be a physician, surgeon, or gynecologist or ophthalmologist, or I'm the specialist. I'm a big guy, and you send him to a BHU or RSC, and he's lost. Wallahi, he is lost. He has no idea what to do there. Somebody comes from the community, he's a bully, and he starts bullying the doctor. He said, "Oh, what the hell I'm doing here? I'm a doctor. I'm supposed to do these things, and it's just not happening." But unfortunately, these things happen. This is the part of the game, I would say. And lastly, the key takeaways. This is the last slide I have. If you see, good governance is not bureaucracy. Bureaucracy is easy to do as an administrator. Yes, no, do this, throw it, this. Governance is the architecture, or it is like an architect. You build public trust. This is the difference. How you get your better governance, good governance. If one person under you is not working, you transfer him out, you throw him out, you terminate. This is bureaucracy. No. You're, as an architect of a public trust, is you make that person work. It is your art, how you do it. This is important. Believe you me, if you can do that, you're the best. You can govern things, you can manage things that way. And that is possible. Get work out of a person to the maximum level. It depends upon the manager. I say manager, I like the word manager, not the administrator, right? Managers, they manage things. Administration is part of it. right? And then I've just given the full lines like, looking at the general principles we have talked about, institutional roles, financial management, transparency rules, tools, and reform is possible with the legal framework and institutional capacity. But in the end of the day, again, I would say what is required is effective leadership. It's not the minister or the secretary or the top people. It is even you, a medical officer sitting in one of the wards or sitting in one of the THQs or DHQs. If you do your work properly, you are part of this. You are doing good to the nation, you're good to the health department, good to the community, and that is what we do. And this is how we are trained. This is how we should be doing it. Our excellence is providing the best care. And it's not only that you are doing it, it is all other departments, other key stakeholders are with us. They are trying to help. But you are the key. You are the coordinating key to them to bring them at one place and do the best. So it should be our motto, it should be our will to provide the best care, best practices to our communities, and we do in a transparent way, and we do the best governance. Thank you very much. I'll stop here. And now, how I stop sharing later on. Can we, how we can open I have a question to ask. If we can open the mics of our participants. Okay, before we start, Dr. Saira, we still have some time, maybe 10 minutes. Is she there? Dr. Saira? Hello?
सर है सर
जी जी
कर सकते हैं
अच्छा let me put one question to just generate a little bit of discussion. आपके अगर वो slide, I'm just asking all the participants. भी हमने वो जो मेरा ख्याल है slide number 3 थी जिसमें मैंने foundation of governance और WHO principles की बात की थी जिसमें transparency थी, participation and so on. My question is, those who are working in different institutions, आपको कौन सा लगता है उन 6 प्रिंसिपल्स में से, उन 6 प्रिंसिपल में से कौन सा प्रिंसिपल सबसे कम आपकी इंस्टीट्यूशन में था? Can anybody talk on that?
सर वो स्लाइड आप दोबारा
अच्छा, स्लाइड दिखानी पड़ेगी. ओके ओके ओके, आई विल डू दैट. आई थॉट दैट definitely I'll do that.
₹200 का कार्ड बन जाएगा, 5 साल बना देगा, ₹200 का आपने कार्ड बनवा लो.
ये मैं शेयर कर तो रहा हूँ. आई शेयर हुई?
सर अभी तो नहीं हुई.
नहीं, एक सेकंड दे मुझे, एक सेकंड. ये क्यों नहीं शेयर हो रही? ये शेयर शेयर कर रहा हूँ. आई इट्स नॉट शेयरिंग. दिस इज स्ट्रेंज. नहीं आ रही.
सर
चले
ये
मैं.
लास्ट टाइम जी जी
अस्सलाम वालेकुम सर.
वाइसलाम.
सर, मेरे ख्याल में जो इफेक्टिवनेस एंड एफिशिएंसी आपने बताया था, जिसमें रिसोर्सेज हैं, स्टाफ है, मेडिकेशन है, इक्विपमेंट है, फाइनेंसेस वगैरह, सर ये हमारे वाइजली यूज्ड नहीं होते और हम हमेशा शॉर्टेज हमें रहती है इन चीज़ों की। मैं जिला हॉस्पिटल
ठीक।
लाहौर से डॉक्टर काशिफ अर्ज कर रहा हूँ। तो
ठीक है बेटा।
ये वाला जो प्रिंसिपल है ये बहुत कम एड्रेस होता है। और अगर हम लिखते हैं लेटर गवर्नमेंट को या रिक्वेस्ट करते हैं तो हम इंटरटेन नहीं किए जाते इस पे, बल्कि उल्टा
राइट।
हमारी इंक्वायरी स्टार्ट हो जाती है।
हम्म। वैलिड पॉइंट है बिल्कुल। और ये बाकी वाले पॉइंट्स के बारे में?
जी सर, जी सर।
ठीक है। तो इसका आपके ज़हन में क्या आता है, इसका क्या हल होना चाहिए?
सर इसका जो बेहतर जो सोल्यूशन है वो ये है कि गवर्नमेंट और ब्यूरोक्रेसी और जो हेल्थ डिपार्टमेंट है उन सबको एक पेज पे अगर हम हो जाएं तो फिर उसका हल निकल सकता है। और जो
तो फिर
जैसे आपने कहा ब्रेन ड्रेन, और जैसे एक बंदा कॉम्पिटेंट है टर्शियरी केयर के लिए और उसको बीएचयू में लगा दिया जाता है, तो उन लोगों को वहां से निकाल के जो उनकी कैपेबिलिटी है वहां पे लेके आना चाहिए सर।
टोटली एग्रीड। आई थिंक वेरी गुड आइडिया। आई थिंक आपने बिल्कुल पिन पॉइंट किया उस पॉइंट को कि जो मतलब इम्पोर्टेंट है। वैसे ये आपने जो बात की ना, सारा कुछ इकट्ठा करके एक जगह पे इकट्ठा आना चाहिए, वेल दैट इज ड्रीम yet come true, unfortunately. But I think I buy your point totally. I totally agree with that. And
थैंक
any
यू सर,
other
थैंक यू।
any other comment, question, anything before I go for another critical question? मेरे ज़हन में था, मैंने कहा वो भी आप लोगों से पूछ लूं। Those who are in the hospital administration, you all are. मुझे ये बताइए, ये जो है हॉस्पिटल मैनेजमेंट कमेटीज वगैरह जो हैं, ये डू दे रेगुलरली मीट? आप लोग करते हो ये? आपके हॉस्पिटल जो स्पेशली जिना सर्विसेज, मेयो, एलजीएच, ये बड़े हॉस्पिटल्स हैं, इनमें इज देयर एनीथिंग गोइंग, इज हैपनिंग अराउंड देयर? एनीबडी?
सर मीटिंग्स तो होती हैं हॉस्पिटल मैनेजमेंट कमेटीज, बिल्कुल होती हैं, रेगुलरली भी हो रही होती हैं, लेकिन इसमें जो आउटकम है वो उतना
जी जी, प्लीज कैरी ऑन।
सर आउटकम इतनी नहीं होनी चाहिए, क्योंककि सजेशंस तमाम लोगों की होती हैं, वर्क भी सब लोग कर रहे होते हैं, लेकिन उसमें आपको एक जो रिवार्ड है वो जिन लोगों को मिलना चाहिए जो काम कर रहे होते हैं, और जो नहीं कर रहे होते उनको बेशक कि आप पनिशमेंट नहीं दें, लेकिन उनको मोटिवेट करें और उनको लेकर आएं। तो सर यहाँ थोड़ा नजर आती है कि जी फिर वो लोग डिस्करेज हो जाते हैं जो काम कर रहे होते हैं।
अच्छा, आपके राय में इसका क्या हल होना चाहिए?
सर मेरा ख्याल है कि ना एकदम पनिशमेंट देना जो है वो डिस्करेजिंग होता है, वो लोगों को बाकी सारी मतलब कोलीग्स और उनको बहुत ज्यादा डिस्करेज कर देता है। इससे बेहतर होता है
डिमोरलाइज
कि जो
करता है, बिल्कुल।
जी
जी जी, कैरी ऑन, सॉरी, कैरी ऑन।
जी।
सर देखें सर, 93 में जिना हॉस्पिटल लाहौर वजूद में आया सर।
जी जी
अच्छा, उसके बाद जिना हॉस्पिटल की एक्सपेंशन होती रही। अब जिना
जी।
हॉस्पिटल जो है जिस जगह पे है वो बाकी एरिया से ऑलमोस्ट 9 फीट नीचे है। अच्छा, ना
ठीक।
हम उसकी बिल्डिंग को अपग्रेड कर सके, ना हम स्टाफ ला सके, ना हम रिसोर्सेज ला सके, ना हम ओपीडी टाइमिंग को एड्रेस कर सके। लोगों की तादाद बढ़ती गई। लेकिन जब भी कोई विजिट आता है, सपोज सेक्रेटरी आ गया, कोई आ गया, उसने उस वो इस फ्रेम ऑफ माइंड के साथ आता है कि मैंने 6 बंदे सस्पेंड करके जाने हैं। तो सर
ट्रू।
ये जो आइडिया है ये ठीक नहीं है।
मैं आपसे टोटली एग्री करता हूँ। अच्छा, इसका भी आप बताएं हल क्या हो सकता है, हाउ यू सी दैट?
सर
मैं
इसका
तो आप
इसका
लोगों
हल
से
ये है।
मैं तो इंटरेक्टिव कर रहा हूँ।
सर इसका हल मेरे ख्याल में तो ये है कि पहले तो वो हमारे मैटर्स को या प्रॉब्लम्स को एड्रेस करें, उनको ठीक करें, उनको रेक्टिफाई करने की कोशिश करें, हमारे साथ मिलके बैठें कि डॉक्टर साहब या जो भी एडमिनिस्ट्रेटर है कि जी डॉक्टर साहब आपके एंड पे ये प्रॉब्लम्स क्यों आ रही हैं। तो वो फिर अपनी प्रॉब्लम्स बताएं उनको, और उनको एक मिल के एक सोल्यूशन निकालें उसका। और अगर उसके बाद भी अगर वो चीजें हल नहीं होती तो फिर कोई एक्शन लें अगर लेना चाहें तो। और उसमें बेहतर है कि वार्निंग्स दी जाएं, ना कि हमें सर हम डॉक्टर्स हैं, सबसे क्रीम है, और हम इतने इंसल्टिंग फील करते हैं इनके एटीट्यूड से। माजरत के साथ मैं ये जरा खुल के बात कर रहा हूँ।
नहीं नहीं, खोल के बात करें, क्योंकि ये तो ट्रेनिंग सेशन है ना जी, इसमें तो मतलब बहुत सारी चीजें हम बात कर सकते हैं, ये कोई हम किसी को कन्वे नहीं कर रहे। मगर वही जरा
तो
मेरी लास्ट स्लाइड अगर आप देखें, सॉरी मैं थोड़ा सा मैं आपको बता दूं, फिर आपसे मैं दोबारा कांटेक्ट करता हूँ इसी पे ही। आपने मैंने देखा था कि ब्यूरोक्रेसी नहीं करनी, हमें गवर्नेंस करनी है। आपका जो सवाल है ना वो 100% इट्स वेरी वैलिड, कि थ्रोइंग आउट और मतलब पिनलाइजिंग एनीबॉडी इज एन एक्सेलेंट, मतलब उनके लिए एक्सेलेंट है, मगर हमारे लिए नहीं है। हमें मौका दें, हमें बताएं, सुने। जी प्लीज,
ठीक।
मैं इससे बिल्कुल
अब
एग्री
स-
करता
अब अब सर गवर्नमेंट ने ऑनलाइन किया, सारे सिस्टम्स को, सारे हॉस्पिटल को इंटीग्रेट किया।
हूँ। जी।
ये एक गुड 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 आइडिया है, लेकिन इसमें यह है कि ओपीडी टाइमिंग जो है पेशेंट की देखने की वो इंक्रीज हो गई है। डॉक्टर्स ट्रेन नहीं है, वो कंप्यूटर्स के आगे बैठने के लिए ट्रेन नहीं है। हम लोग कंप्यूटर्स के आगे कभी नहीं बैठे थे, तो अब
सही।
हमें कंप्यूटर्स के आगे बैठने में, हमारे रिफ्लेक्सेस डेवलप होने में टाइम लग रहा है। तो
एब्सोल्युटली।
पेशेंट्स जो हैं वो बेचारे उसके अंदर, वो उनको भी प्रॉब्लम होती है। और हमें कुछ अरसे की या ट्रेनिंग्स दी जाएं इस हवाले से कि आपने कंप्यूटर्स किस तरह से ऑपरेट करने हैं, और आपने चीजों को जल्दी जल्दी कैसे करना है, ताकि पेशेंट्स को वेट ना करना पड़े। सबसे
अस्सलाम
ज्यादा
वालेकुम
तकलीफ
सर।
ये होता है कि एक बूढ़ा, एक 80 साल का, 80 साल का बंदा जो है वो बेचारा 5 घंटे 6 घंटे उसको बैठना पड़े, तो वो कितनी तकलीफ से गुजरता हो।
अस्सलाम वालेकुम सर।
आपकी जी अब ऐसा एक सेकंड पार्टनर, ये वेरी वैलिड क्वेश्चन, वेरी वैलिड कमेंट्स, और मेरा ख्याल है आपने बिल्कुल पिन पॉइंट सही चीज की है। जी नेक्स्ट प्लीज, को टाइम कम है। आप
सर 2 मिनट
नेक्स्ट।
रिमेनिंग है इस सेशन के लिए।
जी वही मैं कह रहा हूँ,
जी,
जल्दी जल्दी इसको।
थैंक यू सर।
जी एनीबडी एल्स? वेरी वेरी गुड पॉइंट्स कमिंग अप। आई रियली लाइक द कॉन्वर्सेशन, दिस इज वेरी गुड। हमारे पास ही 2 मिनट रह गए। एनी बर्निंग थिंग कमिंग अप?
सर इसको फिर अगर कंप्यूटराइज, अस्सलाम वालेकुम सर। सर ये अगर इसको कंप्यूटराइज और इस तरह डाटा करना है तो मेरी ये रिक्वेस्ट थी कि पेशेंट लिमिट किया जाए कि एक डॉक्टर कितना पेशेंट देखता है। आप 300 या 400 पेशेंट एक ही आउटडोर पे दिखा के उसको कंप्यूटराइज डाटा पे शिफ्ट नहीं कर सकते ना सर। अगर आप 3 या 4 घंटे का ओपीडी है, पर पेशेंट आप देखते हैं कि कितना टाइम मिलता है, उसमें कंप्यूटर उसका टैग करना, उसका फाइल
हेलो।
में जाना, ये इसके लिए टाइम चाहिए। नहीं होगा ना कि डॉक्टर 20 पेशेंट देखेगा, 25 पेशेंट देखेगा, तो डाटा मैनुअल।
नहीं, आप बिल्कुल, आपकी बात से मैं 100% एग्री करता हूँ। मेरा ख्याल है जैसे वो कहते हैं ना कि जब खाना बनाना तो सारे इंग्रेडिएंट्स होंगे, मिर्च मसाला होगा तो बस डॉक्टर्स, आपके पास हर चीज अगर होगी तो आप ये 400 पेशेंट देख सकते हो। एक बंदे की ह्यूमन कैपेसिटी है ना, 400 कौन पेशेंट देख सकते हैं? नॉट पॉसिबल एट ऑल। तो वो इतने डॉक्टर्स या तो दें। तो ये सारी चीजें एब्सोल्युटली आई टोटली एग्री, और मेरा आई एम वेरी हैप्पी कि आप लोगों ने खुल के बात की है, और जो मेरे जेहन में था प्रेजेंटेशन बनाते हुए, ये सारे पॉइंट वैलिड इसलिए हो गए कि आप लोग तो प्रैक्टिस में हैं इस वक्त, एंड यू आर फेसिंग दैट एवरी डे। तो आई होप कि ये जो हमने डिस्कशन की है और जो मैंने प्रेजेंटेशन दी है, इट विल बी यूजफुल फॉर यू पीपल
सर थैंक यू वेरी
इन
मच,
डेज
आपकी
टू कम।
प्रेजेंटेशन
हम
बहुत
मतलब
अच्छी थी।
चाहे वन पर चाहे वन चाहे